Everybody see?
Yeah,
Yes.
all good. So I may as well just get it started. So welcome everyone to our first academic event of the year. Just quickly before we start, I'd like to acknowledge the traditional owners of the land on which we're meeting. So for me, that's Rwanda people. And I'd like to pay my respects to the elders past, present, and emerging. There will be an attendance form in the chat. So please feel free to fill that in. We're probably giving out a keep cut we'll do like a raffle or something. So feel free to increase your chances by signing up. If you have any questions, chuck them in the chat. We're going to save them till the end of the talk and then just knock them out. And without further ado, I'd like to introduce our speaker for the day, who's Teresa Leung, who's a consultant hematologist at the hospital, who's very kindly agreed to give the talk. So here you go.
All right, nice meeting you, everybody. Yes, it's a pleasure to be invited to this group. We're all very intrigued and delighted to find that there is actually that much interest as a medical student level towards hematology. And the talk that I'm going to give today is about anemia and iron infusion. And it's a very down-to-earth talk with some cases and also some discussion. So I will be going through this in an interactive manner, or as interactive as I can from a Zoom platform perspective. And hopefully, yes, if you know the answer, either sing out or you can type it up on the chat. And the aim is to try and have some fun as you learn this. Now, let me just try and make sure that I can navigate this. Am I sharing the right thing?
Yeah.
Because it said my share screen is paused, which is, but you can still see it, right?
We're currently seeing the screen that says about me.
Yes, okay. Let me just make sure I can see it too, because it's a bit of a problem when I can't see the screen that I share. Let me just mute this. I'll just stop share and share again. That might actually fix the problem. Try this. Interesting. Okay, let me start. Okay, I can see it again. I hope you can still see the same about me.
Yes.
Okay. Maybe what I should stop doing is to try and multitask. So I'll leave the chat screen to you because I can't quite see the chat screen in a very big mode, but that will do. All right. So yeah, I thought before I start the talk, I'll tell you a little bit about me as a person. So I am a physician as a hematologist, but apparently I'm not the most common type of physician specialist, because when I try to look it up, the listed physicians here, as you can see, are pediatricians, neurologists, dermatologists, anesthesiologists, psychiatrists, even infectious disease physician scores, but not hematologists. So we're definitely not a common breed. At the same time, I'm also a pathologist. So one of the interests that I do is bone marrow biopsy. Is one of the only procedure that I should have still some memory of doing now, and is a very 19th century procedure in the sense that we don't have radiological guidance, we don't have any fancy equipment, but a very, modernized looking hand drill, but is a very useful procedure in the field of hematology and helps us diagnose a lot of critical life-changing conditions, including leukemias and other types of lymphomas, hemolytic anemias, etc., etc. So it's part of what I do as well. And I also report bone marrow biopsies as well as blood films, flow cytometries as part of my pathology hat. And outside of that, I'm also a bit of a singer. So this other photo is me singing at the Christmas caroling at the Northern Hospital during the first break we got from our lockdown last year. And finally, I'm a bit of a cat lover as well. So you can see that that's not my cat, actually, that's my friend's cat, but I do have a collection of cat photos that I try to show people in my free time and on my Instagram. So that's me, the complex person that is outside and inside hematology. Now, so what are we here to learn tonight? Firstly, iron deficiency is common. Every one of you, I hope, would have learned how to interpret iron studies as part of your learning in medical school and learn about the different types of anemias, so forth. But when you apply your textbook to a real case, you would find that life is not so simple. People don't just present with textbook case of iron deficiency anemia or B12 anemia or anemia of chronic disease. They all come in with a mixture of everything. And sometimes what you see in the textbook is not as straightforward when it comes to applying it to a real person. So I'm hoping to show you a layer of that complexity and also learn about the range of intravenous iron products available, because there are quite a number of brands out there. And as interns, whether you're medical, surgical, gynecological, emergency department, especially if you work at the Northern Hospital where there is a diversity of culture and people who have average probably 3 or 4 babies a year, not a year, sorry, over a matter of their reproductive life, then iron deficiency is more common than you think, and all of you have to learn to deal with it and manage it. So the third point brings you to how to manage iron deficiency as a doctor, and also what you should be looking out for when you consent someone for an iron infusion. So let's start with a case study. We've got a 46-year-old lady presented to ED 2 weeks ago. With 2 weeks of a bilateral lower limb swelling, as you can see in that photo here. The photo I've shown here is not the and the ultrasound confirmed that there is a right lower limb DVT. And she's also known to have generalized arthralgia and myalgia. And at this stage, let me see what is the further assessment and plan and management plan that you have for her? I'll give her 10 second, 20 second for people to type in their response, or if you want to sing it out. This is something that you will see pretty much once in your ED, and most of the time is not as dramatic as what you've seen on that photo here, but that photo basically shows an uneven diameter lake. one is redder than the other as well. So when you compare one leg to the other, when you just look at one leg, it's not that obvious. So when you examine someone's lower limbs, always needs to expose both, because once you compare the both, the abnormality becomes actually quite striking here. And it would have been extremely tender to touch this lady's calf as well too. So if you see something like this, then definitely you need to organize an urgent ultrasound to rule out a DVT. Okay, so I see ESR, CRP, RA, is that rheumatoid factor? Yes, so that is something that you will want to do as a screening to investigate for the myalgia and nephralgia. But what we've got here is someone with a newly diagnosed DVT. So what are you worried about in someone who's got a newly diagnosed clot in the leg? Yes. So I'm seeing responses here to say that signs of PE, and someone wants a CTPA. And then, yep, I can see that take history, vitals, end of bed examination. So that's all relevant. Yeah, and that's what I'm looking for, because obviously at this point, what you've got is someone who may potentially have extensive clot that extends beyond the leg. And what you want to know is whether this person has a PE, because if it is, it's a life-threatening emergency. So yeah, you want to quickly take a look at the vital signs, have a look at the rest rate, saturation, blood pressure, heart rate, etc. That's probably the most important thing. And if there is any vital sign that's out of whack, in terms of tachycardia, hypoxia, then you want to go straight to a CTPA to rule out a PE. The other very useful quick test to do at this stage is an ECG, because you may have learned about that people with PE, what signs do they get on the ECG? Yes, so sinus tachycardia is the most common. And also the classic, but not always observable textbook feature is S1Q3T3 on the ECG, which you really only get in massive PE. And also the other tests, blood tests, any useful blood tests that you would do? Okay, so D-dimer and troponin. D-dimer, slightly controversial. You would probably do it before the ultrasound if you're not sure if that person has a clot or not. When she first come in with the leg swelling, and if you think the leg swelling has other explanations, then you would do a D-dimer. The problem with D-dimer in this particular setting is this lady also have generalized myalgia and nephralgia, and there is very likely to have some underlying inflammation in her. And D-dimer is an acute phase reactant. So I think one has to always remember when you order the D-dimer, there are lots of things that causes false elevation of D-dimer. One of them is any inflammatory condition. Other one is pregnancy, and also any malignancy. So in this case, the D-dimer, I can probably bet even without ordering it that it will be elevated. So in a sense, it probably doesn't help you that much. But in other cases where there's less obvious, a D-dimer might help you differentiate whether I want to investigate this further or do a CTPA or not. Troponin, yes, once we prove a once we prove a PE, then there is a role for troponin. I think more what I'm looking at this particular point, which is where you have diagnosed a DVT but not quite sure whether she has a PE, is a blood gas. So an ABG would probably help you quickly establish whether someone is hypoxic and also what their pH is like, because if there's any signs of compromise, then again, you would move straight to a CTPA. would you do a coagulation test? The answer is, if I suspect that there is a DVT, I would, because you want to think of the next step, which is how would you manage the patient? Because you know that someone has a clot. What is the treatment, regardless of whether she had a PE or not? Yes, so that's right. So the word I'm looking for here is anticoagulation. Fibrinolytics I could see coming up. So that is a slightly more, aggressive way of treating a clot, let's put it that way. So anticoagulation, as you know, means putting someone on anticoagulant to try and stop further clots from forming, because anticoagulant actually doesn't actively break down the clot. All it does is it thins the blood and it stops the new clots from forming, allowing the body time to break down what existing clot is already there. Whereas fibrinolytics goes in and basically aggressively breaks down the clot actively. So the bleeding risk of fibrinolytics in turn is higher than anticoagulation. But either way, because we are thinking of blood thinning therapy, I think doing a coagulation test at this point as a baseline certainly is useful. And we will probably want to see it before we start anyone with anticoagulation. And definitely we will need to see it before any fibrinolytic therapy. And fibrinolytics would only be indicated in certain types of high-risk PE. So not everybody who has a PE will get fibrinolysis. Certainly if she only had a DVT with no signs of compromise, or if you did a CTPA, you didn't find a PE, then you would not be using fibrinolytics to treat her. All right, since I'm not giving a thrombosis talk, I'll move on. But I thought this is an interesting point to start discussing things. So this lady doesn't have any respiratory distress, not hypoxic, didn't have any tachycardia. So when we look at her op chart, we're quite comfortable that she did not have any signs of respiratory compromise. Therefore, we did not go ahead and CTPA her. We commenced her on rivaroxaban, which is NOAC, new oral anticoagulant, or DOAC, direct oral anticoagulant, whichever way that you want to define it is the same. And this is probably a slightly harder question. What type of NOAC or DOAC does people know on the market apart from rivaroxaban? Anyone knows other types of NOAC or DOAC? Yep, okay, good. So yes, DOAC mainly is a factor 10A inhibitor, the apixaban and rivaroxaban 10A inhibitor. Dabigatran is a slightly different point of acting, so they're not 10A inhibitor. They're, I think, factor 2 from memory inhibitor. So, but they're all lumped into the class of DOAC or NOAC because they're actually not the classical form of anticoagulant warfarin, which is a vitamin K antagonist, as we all know. So the difference between rivaroxaban, apixaban, mainly because they both act on factor 10, I'll compare the two of them, is a daily versus a BD dose. So rivaroxaban actually is not completely correct. So with NOAC, we all need a loading dose because when you first start, even for warfarin, anticoagulation, we need to build up the concentration in the body quickly, the drug concentration. So we usually would intensively load someone up and then put them onto maintenance dose. So when I apply it to rivaroxaban and apixaban, rivaroxaban has a loading dose of 15 milligrams twice a day for 3 weeks. And once you finish loading, you drop back to 20 milligrams daily as an ongoing dose, maintenance dose. And that's still a therapeutic dose of it. Whereas apixaban is a BD dosing throughout, so it's less confusing. However, if your patient is not compliant with medication, it's probably a harder drug to take in the long term. The loading dose of apixaban is 10 milligrams twice a day for 7 days, and then step down to 5 milligrams twice a day for the duration of therapeutic anticoagulation. And I'm seeing a question here. Do we need low molecular weight heparin initially in low X like warfarin? No, this is the answer. Because the reason why we need to load up warfarin is because of the pharmacokinetics. So the warfarin half-life is very long. It's up to 5 days. So it will take 2 or 3 days for a dose to become effective. And also the other aspect of warfarin is it will also consume your protein C and protein S concurrently. And if you remember about the thrombophilia, if you learn about thrombophilia, one of the inherited conditions is protein C and protein S deficiency. So protein C and protein S deficient is actually a clot promoting condition. So initially when we load someone of warfarin, because it depletes protein C and protein S, we need to cover them with bridging clexane. Otherwise, the person would actually clot, and I have actually seen that happen. Someone loaded someone on warfarin without starting them on concurrent low molecular weight heparin, and the person comes back 3 days later with a much worse clot. So that's an important concept in warfarin bridging, but not so much in NOACs, because essentially, if you think about rivaroxaban and apixaban in particular, they act on the same point of enoxaparin 10A. They're both anti-10A. So rivaroxaban and apixaban, if you like, can be treated like an oral enoxaparin. Okay, so moving on here to our topic of the day, which is iron. This lady came back 1 month later after starting therapeutic anticoagulation for her clinic review, and she reports menorrhagia, also reporting persisting polymyalgia with synovitis as well. And we always, because we're hematologists, make people come back with some blood tests. So these are her bloods. As you can see, she's slightly anemic with an MCV of 84. Ferritin is 42, but the total iron is low. She's also got extraordinarily high CRP and ESL. So the question here is she iron deficient? And whilst I'm waiting for responses, just a little bit of a tip in your future if you have to prescribe NOAC, anticoagulant, apixaban, or rivaroxaban, or dabigatran. Currently, the PBS indication for using NOACs in PE and DVT is only limited to apixaban and rivaroxaban, not dabigatran. But PBS does allow dabigatran, apixaban, and rivaroxaban to be used for the indication of AF. So slightly confusing, and that's because of trial data in terms of prescribing. So in the hematologist world, because we mainly prescribe for PE and DVT, we play around with rivaroxaban and apixaban mainly, whereas a cardiologist plays with dabigatran as well as the other two. And also between rivaroxaban and apixaban, we found that in a lot of young female patients in particular, they do come back reporting their period becoming heavier once they commence with rivaroxaban. And the same finding is not noted in apixaban. So my practice these days is to prescribe someone who has history of menorrhagia, or if they're young female, I tend to go for apixaban. And there are various theories behind this. And I think one theory states that there's probably more receptors on the endometrium that's sensitive to rivaroxaban compared to apixaban. But I don't think there is widespread study to say why, but certainly anecdotally, I've noticed some patients had to actually be readmitted with severe anemia and also bleeding from rivaroxaban. Okay, so going back to the responses, potentially yes, because inflammation ferritin can artificially normal. Yep, as an acute phase reactant, that's very right. And the low transferrin saturation increases suspicious of iron deficiency. Yes, and that's the observation that I like to make here, is that ferritin in the setting of acute inflammation is not an accurate indicator of iron deficiency anymore, even though in a classic situation of iron deficiency, you're always told to order a ferritin. And I noticed a lot of people out there just ordered the ferritin as a screening test for iron deficiency. Unfortunately, sometimes that practice can be flawed because if the patient had some kind of inflammatory condition, the ferritin can frequently be falsely normal. Obviously, if the ferritin is already low even in that condition, then the patient is definitely iron deficient. So it has good specificity, but it's not very sensitive. So in the setting of inflammation, transferrin saturation is a much better indicator or preserved indicator of iron deficiency. And you really have to order the whole iron studies to get the full picture of what the actual iron metabolism is like in someone with chronic inflammation. And yes, so I'm seeing ferritin needs to be rechecked once inflammation and infection has cleared. Yes, so that's in general correct as well. But yeah, I think the main thing to know here is don't rely on the ferritin alone in these circumstances. And here are some pictures. Since I'm a hematologist, I like my blood fumes. So the classic iron deficiency anemia picture is microcytic hypochromic anemia. I'm sure you have read about it many times in the textbook. That's what it means by microcytic hypochromic. So we use a small lymphocyte as the guide or gold standard of what a red cell, normal red cell size should be like. We compare a normal red cell to a small lymphocyte. In normal circumstances, the red cell should be about the same size or just slightly smaller than a small lymphocyte in blood. But in this occasion, you can see that the red cells are much smaller. It's almost only about half the size of a small lymphocyte. So this is microcytosis. And you can see the rim of the red cell in the middle. They're usually a little bit of pallor, but generally not more than 1/4 of the red cells or not at all. But in this case, more than half of the red cell is pale, and it appears that the red cell has a red ring. So this is what we call hypochromic. And also next to the round red cells, you see the elongated red cells. We call these pencil cells, and they're quite classic in iron deficiency anemia too. So when I see a blood film like this, without even looking at the indices, I can pretty much diagnose someone as iron deficient and anemic. It's quite powerful. But when you look at the blood test from your screen without the blood film, what you're looking for is low MCV or MCH. And by classic textbook definition, the ferritin should be lower than 30 and the transferrin saturation less than 20, and also a high transferrin as a compensative mechanism. again, you would probably read that from textbook many times courses. I think I would only generalize this because I don't want to repeat everything. And this probably rules applies to all malabsorption syndrome. Is any cause of any deficiency really is a imbalance between intake. So if you have a decreased intake, for whatever reason, you'll be low. If your absorption is impaired, for whatever reason, your absolute iron content or whatever substance that you're looking at, the content would be low as well. And the other mechanism that you'll become deficient is this increasing destruction or loss. So you apply it to the case of iron, inadequate intake would be translate to a dietary insufficiencies. And out in the northern, where we serve a large ethnic community who are vegetarians, this is actually not uncommon. And we also serve people in low socioeconomic background. We've recently just discharged someone who had a combination of folate and B12 deficiency, and that's because he hasn't been eating the right food for the past 12 months. So it's certainly something that can happen. So take a dietary history is important. Perhaps the most common cause of iron deficiency in anemia in our society is probably going to be blood loss. And blood loss can come from the GI tract. As you know, colon cancer can present as silent iron deficient anemia in younger age females, menorrhagia, and also pregnancy. Can also result in excessive blood loss, causing iron deficient anemia from consumption. And we look at the absorption side of things. Iron is being absorbed in the stomach as well as the first part of the duodenum. So any problems or pathology that affects that part of the gastrointestinal tract can potentially result in an impaired absorption of iron. And one of the things that I observe in females mainly who have bariatric surgery or gastric bypass for cosmetic reasons, weight loss, they come back with quite severe iron deficiency. And those people can present with recurrent iron deficiency despite being on adequate diet because they've lost the means to absorb the iron. And knowing that is important because people with impaired absorption potentially would not respond to oral replacement as well as opposed to people who have an intake problem or a blood loss problem. And worth noting that drugs such as PPI and anti-H2 inhibitors can also cause impaired absorption of iron. And that's because iron is actually ideally absorbed in an acidic environment. So when we educate someone to take iron tablets, we always encourage them to take it with vitamin C tablets or orange juice because of that. Now, a little bit about anemia of chronic inflammation. So anemia of chronic inflammation is actually the most common anemia that you will see in hospitalized patients, so as well as elderly population. So as an intern in the hospital, next year, you will definitely come across people with chronic inflammation. And that's what makes iron studies in patients difficult to interpret. And if you just order a ferritin for your hospital patients, you almost can't interpret it accurately whether they have iron deficiency or not. So yeah, when they're a hospital patient, I always encourage people to organize to order full iron studies. And lots of things can cause anemia of chronic inflammation, including infections, autoimmune disease, cancer, kidney failure, cardiac failure, obesity, poorly controlled diabetes, basically any conditions that would potentially put you into the hospital will cause anemia of chronic inflammation. And the process is driven by inflammatory cytokines and hepcidin, which is a master regulator of iron. And essentially, diagnosis of anemia of chronic inflammation is difficult because we don't have the one test at bedside readily available that can tell us if this test positive is chronic inflammation anemia. Therefore, taking a clinical history remains the most important means, and then knowing how to interpret the iron studies sensibly remains the most important means of diagnosing anemia of chronic inflammation. Hepcidin is an interesting hormone, if you like, to discuss. In the academic setting, we can order hepcidin level, but unfortunately, it's not a very easy bedside test to order. But the interesting thing about hepcidin is basically it regulates the iron. Is the main hormone that regulates the amount of iron being absorbed. So iron is one of those elements that the body only regulates by one way, which is absorbing. So once there is excess iron in the body actually can't excrete iron actively. All the body can do is to recognize that there is excess iron in the body and stop absorbing it from the gastrointestinal tract. And this mechanism is governed or mediated by hepcidin. So the point where hepcidin is released is prompted by the macrophages. So excess ions are normally stored within the macrophages, and the macrophages live in the liver. So that's why the liver cells are the main source of ferritin, where excess iron is stored. If you have a liver problem, your ferritin would also be falsely elevated as well, because your macrophages are being broken down prematurely, releasing all the ferritin into the blood. So that's another story. But basically, in the normal body, when macrophages stores enough iron, they would activate hepcidin release. And when hepcidin is released, it would cause ferroportin expression to be downregulated. So the iron, which is absorbed across the enterocyte, which you can see on the diagram there, will not be transported across to the circulation. And when the enterocyte is expiring, because the endothelial cells turn over every 40 hours, the iron will just go with it. And at the same time, hepcidin would also stop the ferroportin on the macrophage surface being transferred out onto the circulation. So the excess iron would stay inside the macrophage itself until all the iron has been used up. And then hepcidin levels will be decreased, and then the body will start absorbing iron again. So that's how the hemostasis, if you like, of iron takes place. And from a practical perspective, because of all the reasons that I stated before, iron deficiency and anemia of chronic inflammation frequently coexist, which means that when you look at someone's FBE, even though they're anemic and iron deficient, the MCV can be normal. In the cases of ferritin, it can either be reduced or it can be normal. So anywhere between 30 to 100, or if they're severely inflamed, even greater than 100, can be seen micrograms per liter. So as someone have said before, transferrin saturation becomes the most useful parameter to interpret here. So if transferrin saturation is less than 20%, then we can speculate that this person is likely to be iron deficient as well. And if you look at other parameters, they're less useful, but transferrin would be low as opposed to high in a classic iron deficiency setting. And obviously, there will be history of inflammation and elevated inflammatory markers to support concurrent existence of chronic inflammation anemia. So let's go back to our patient now. Because of the menorrhagia, as I said before, we switched this patient to apixaban. She still needs her anticoagulant because she's only 1 month into her DVT treatment. And we recognize that even though she has inflammation, she's probably iron deficient as well. And from a history perspective, her menorrhagia would explain why she's iron deficient. So we commenced her on some oral iron supplement, and we also educated her about iron-rich food. from addressing the inflammation perspective, yes, we did do all those things that you said before, ESR, CRP, autoimmune screen, vasculitic screen. We ordered all of that and they were all negative. But that ESR and CRP level is quite astoundingly high, so we don't really want to sit on it. We referred her to our rheumatology colleagues who, after examining the patient, thought the patient has what we call seronegative inflammatory arthritis, and she was subsequently commenced on prednisolone. So at this point, I thought I'll just quickly go through with you what's iron-rich diet. Basically, iron source is the richest in animal. So if you're a vegetarian, you have to work twice as hard to try and get as much iron in the system. As you can see, red meat fares better than chicken, much better, in fact, in terms of providing iron, and even pork. So usually, apart from asking whether they eat meat, I specifically ask whether they eat beef or lamb, in fact, because a lot of patients will tell that, oh, I'm not vegetarian, but I only eat chicken. And that is not a good diet in terms of addressing iron deficiency. Interestingly, deep sea fish like salmon and tuna has a fair bit of iron, much higher than chicken. So yeah, something that you can teach your patient about. If they don't like eating red meat, they can eat deep sea fish instead. For the vegetarians, the main source of iron comes from lentils and probably bean-like products. So we have to ensure that if they're not meat eater, that they need to have good amount of lentils in their diet. And also the good old tail of spinach is also a good source of iron as well too. But the key is that they need to eat it every day to get enough iron. If diet is not enough, which is frequently the case, then oral iron supplements should be introduced. And I've listed here some of the iron brands that's available over the counter in the chemist. And I've listed them based on the iron content, elemental iron content. So as you can see, the highest elemental iron contents is ferrograd or ferrograd C. The C stands for ascorbic acid, so vitamin C. The reason I've explained it before is iron absorption is much superior in an acidic environment. So if the patient can't drink orange juice or eat something rich in vitamin C as with their tablets, it's probably better to use ferrograd C. However, ferrograd C also had side effects. The iron content is high, but it can also cause a lot of bloating, abdominal pain, as well as constipation. So it's actually not a very easy to palate tablet. A lot of patients give up after a week or two. There is now this newer format at the bottom of the diagram, Maltofer, that is supposedly marketed by the company at least to have less GI side effects. And it has a syrup form as well for those who doesn't tolerate tablets form very well. So I would switch these patients who have problems tolerating ferrograd to Maltofer as a try, but still some of them can't tolerate it. And it's very hard for patients to describe what type of iron tablets they're on, especially if you work in a health service like Northern, where they don't speak English as the primary language. So we designed this diagram, and also it's good learning for us too. So they know what the iron tablets looks like, and they just need to point what that they're taking, and I can easily do my history taking that way. Note that FIFO has both iron and folic acid, and is probably the best supplement for someone who's of childbearing age to take. Problem is that it probably doesn't have as much iron as ferrograd C. So if they're very anemic, it's probably not the first line treatment, but otherwise it's quite well tolerated. The recommended dose and duration varies. In the good old days when I was a medical student, I was told that you need to give them 2 tablets a day if they are iron deficient and have anemia for 4 to 6 weeks. But we soon realized that this is not practical because of the reasons that I said before. Most people give up after a week or two because of the GI side effects. So now I would more gently recommend probably 1 tablet daily for 6 to 8 weeks. And if they're not anemic, even if the MCV is a bit low, I would probably say you can start off with 1 tablet every alternate days, because I think the importance is the longevity of the treatment rather than the intensity of the treatment when it comes to oral replacement. Because once the patient develop a negative impression of the tablet, it's very hard to convince them to go back again. And obviously that means if we can't intensively load someone with oral iron, if the iron deficiency is severe, we would be turning to iron infusion. Okay, so going back to this patient, 6 weeks later, we review her again with some bloods. She said the period is better, but still on the heavy side. She claims she's been compliant with the iron tablets and the diet that we recommended her. And these are his bloods, her bloods, sorry. Hemoglobin 102, MCV is 83. Of note, the CRP has come back down. It's only 5 now, so the prednisone is working. And her ferritin is 7 with a transferrin of 3.43. That's a typo. A transferrin saturation of 7. From what I've told you before, this is now turning into true iron deficiency. So once we settle the inflammation, we have unmasked the true iron deficiency picture in her. What do you do now? Yes. So basically, this is a leading question because we've already done everything else. So the next thing is IV iron. So the indications of giving someone intravenous iron is pretty sensible if we've tried oral and dietary method for a good 4 to 6 weeks and it hasn't been working, then we need to switch tack. Also, if someone is severely symptomatic and can't wait for the oral iron to kick in, then we would use IV iron as a first line of treatment, and it usually occurs when the hemoglobin is less than 100. The other indication to note is, as I said before, if there's something impairing your absorption, such as inflammatory bowel disease, or if you have gastric bypass, you're not going to absorb your oral tablets as effectively. So again, if the iron deficiency is severe enough, go straight to an IV replacement. Interestingly, people with chronic renal impairment also does not respond very well to oral iron. I'm not quite sure why, actually. So those people would also preferentially go on to intravenous iron, because without being iron replete, we can't give these people EPO or any erythropoietic stimulation agent. And also, yes, the other indication obvious is people who suffered ongoing blood loss that exceeds the capacity of oral iron to meet the needs, such as people with severe menorrhagia that just keep losing bloods every day waiting for hysterectomy, for example. There are also some contraindications for IV iron. One of the main ones, which is very, very rare though, is known severe hypersensitivity, such as anaphylaxis or anaphylactoid reactions to iron. The other one, which is less well known, but just as important, is people who have iron overload. So if they have a history of known hemochromatosis, or they already had a transfusion-dependent anemia, we try to not give them IV iron because, as you know, blood cells have a rich source of iron, and we have people who have myelodysplasia who probably needs transfusion every 2 weeks. And those people would be at risk of iron overload that it is. So we don't want to give them extra iron load. And one interesting phenomenon that I've come across as a hematologist is polycythemia rubra vera. So we have patients who come in with a relatively normal hemoglobin, but not anemic generally, but have a very low iron profile with low ferritin. And as a good doctor, the cardiologist, the renal physician, decide to replenish this person with iron, and then 2 weeks later, the hemoglobin becomes 200, and the hematocrit starts to rise again. So what we've done here is we have unmasked a myeloproliferative neoplasm in the form of polycythemia rubra vera. And that is because people with a myeloproliferative neoplasm, part of the compensatory mechanism that the body does to suppress the count is to actually keep the iron levels low. So when we artificially go and replace these people with iron, we actually make this condition worse. And we've diagnosed quite a few MPN from this maneuver, if you like. And yeah, those people obviously should not have iron, even though their iron studies are low. And the last thing to remember is early pregnancy. So when a person of childbearing age come in and you decide to give iron, always try to ask, could you be pregnant? Or if you're in ED, just do a beta HCG. People who are iron deficient in the first trimester should only receive iron oral supplement because there is no information about teratogenicity of most of the IV iron products. The three choices of iron replacement IV we can find on the market is iron carboxymaltose, iron deficiency, and iron polymaltose. I'm not going to go into the nuances because you're not going to prescribe it today, but those are the three different brands that you can find. The main thing with carboxy and deficiency is there is less signal of a severe reaction. It's a newer iron preparation with a smaller sugar molecule. So all the deficiency and carboxymaltose is a sugar molecule attached to the active iron. And the oldest form of iron infusion that I used to deal with as an intern is iron polymaltose on your right-hand side. And as the name suggests, polymaltose is a big polymer, so sugar molecule. And the way that it's designed, the bigger the sugar molecule is, the more likely that the person can react to the sugar molecule and cause an anaphylaxis or anaphylactoid reaction. So when I was prescribing iron infusion those days, we give a test dose, and then I have to sit next to the patient for the next 30 minutes to make sure they don't have anaphylaxis. And if they survive that, then we give the rest of the infusion, and all the time needs frequent ops. And yeah, we can't be too far away from the patient, etc. So it's actually a big deal. Whereas now with the carboxymaltose and the deficiency, because of the smaller sugar molecule, we almost never see true anaphylaxis. Again, this is what the hospital at Northern Health uses as a guide to say who gets what type of infusion. You don't have to go into details about it, but essentially, most people will get carboxymaltose or deficiency because PBS only pay for them as an outpatient. Whereas for inpatients, we still give polymaltose because there's actually quite a price difference between polymaltose and carboxymaltose. So yes, unfortunately, price do come into our medical decision making. So in the Northern Hospital, it is mandatory that we have to obtain informed consent for iron infusions. Not everywhere your work will demand the same, but I think either way is a good idea to inform your patient what reactions that they're likely to experience. And the most likely experience that they're going to have, especially with the newer type of infusion, is going to be non-specific headache, dizziness, muscle, or joint pains. And these occur up to 10 to 30% of patients, can be delayed onset up to 72 hours. So I have patients who go home after an infusion and tell me I felt terrible for the next 2 or 3 days. And then I felt better. And that's because of this non-specific flu-like reaction that they have. And during COVID, yeah, it's often, confused as COVID symptoms too. And you really can't tell the difference. So they all end up scoring a COVID swab. And the other more dramatic reaction, which is more immediate onset, is a chest pain, shortness of breath, which can be confused with anaphylaxis reaction frequently. But when you look at their ops as a doctor, they are not compromised. So that's how we tell the difference between that and a true severe allergy and anaphylaxis. So that's what those meant to be spelled, which is only occurring in less than 0.1%, probably in newer preparation, and maybe about 1% in the polymaltose preparation, which you will observe all those symptoms above, plus hypoxia and probably low blood pressure as well, to those cases, yeah, you need to give adrenaline and steroids promptly, and the patient may need hospital admission, and obviously oxygen. Whereas for the chest pain and shortness of breath, those life-threatening vitals preserved reactions, most of the time you can deal with it by just stopping the infusion, calming the patients down. They might just need a bit of oxygen because they tend to hyperventilate by that stage, and restarting the reaction at a slower rate. And I'll go into it, what's the difference between the two reactions. Lastly, but importantly, permanent skin pigmentation is something that I always tell my patient now, because as you can see in that photo there, we have had incidents in our hospital where there are large permanent staining forming on someone's arm where the infusions went in, and required plastic surgery referral because the area involved was so large and the stain was so permanent. And that reaction is not really a reaction per se, is really a technical issue, in a sense that the drip that the patient is having the iron infusion from is leaking, and no one discovered it soon enough to cause basically the whole bag of iron to leak into the skin. So to prevent that, firstly, site a cannula in a secure vein. And once you have secured the vein, we would prefer people to use a distal vein rather than proximal vein, just because even if there is a leak, a distal vein would leak slower and the stain would be smaller. Whereas the most common vein that's involved in those incidents is an old cubital fossa cannula that's probably like 2 days old or something, just about to be dislodged and probably leaking as it is. And if you have to use the cubital fossa, try to do a fresh cannula. Make sure you secure and immobilize the patient's elbow so they don't dislodge the cannula as the infusion goes in. Now, this is a complicated diagram, but I guess all I wanted to say is that there are different levels of hypersensitive reactions to iron. The mild ones, which is what I described before as those 5% or 30% reactions, are the more common ones, and they're known as fishbone reactions. They're related to the labile free iron in the infusions. Whereas the more severe but rare one, the anaphylaxis reaction, is related, as I said before, to the sugar molecule moiety in the infusion, and is much rarer observed. And there is a protocol in each hospital, which is of similar nature, to tell you how to deal with it. The mild reactions that generally don't need steroids, but the severe ones, prompt administration of adrenaline and steroids is recommended. And obviously call MEDCO on the patients because their vitals will be compromised. And who are more at risk of getting iron infusions reactions? Obviously, someone who has a previous reaction to intravenous iron. The rate is quite important as well. So we're actually doing a review of our iron infusion rate at one of the products at our hospital, which is newer. And we suspect the rate was what's causing an increased amount of those fishbone non-life-threatening reactions in our patients. So we're preparing to issue a amendment to our protocol. And obviously other concomitant airways disease and conditions that affects the immune system, like mastocytosis, and having less reserve, such as old age, all those things would affect it. And the most common that I see risk factor is anxiety, actually. Also, another interesting fact about one of the products, iron carboxy maltose, there is a signal coming out after several years of administration that this product increases the risk of hypophosphatemia. And by that, the definition is less than 2.0 milligrams per deciliter. And this is a trial that compares iron maltose and iron carboxy maltose, 1,000 milligrams and 750 milligrams. So they didn't really do it head to head, unfortunately. But even at a lower dose of carboxy maltose, you can see that they have a much higher rate of developing hypophosphatemia at any days after the infusion up to 35 days is still detectable. The mechanism of it is generally unknown, but we've identified that the iron carboxyl maltose seems to upregulate this factor called fibroblast growth factor, FGF23, which is a growth factor from the osteocytes. And it in turn affects turnover of phosphate and increases its excretion, resulting in the hypophosphatemia. And the risk factors that would exacerbate that is the low vitamin D in the system and high PTH. So one of the scenarios that we found ourselves ended up in is patients who had osteoporosis, probably because of low vitamin D, needing bisphosphonates. They get quite severe hypophosphatemia if we administer that together with IV iron. And we've now made a policy to not administer about 2 weeks or 3 weeks before we administer them. And we also recommend people would check the vitamin D before administering carboxyl maltose. And also be vigilant, because the symptoms of hypophosphatemia is actually not very specific, as you can see. It's lethargy, weakness, muscle aches, that sort of thing. Finally, going back to our patients, 8 weeks later, our patients returned with a hemoglobin 115 now and the ferritin of 121, and this is after an iron infusion. So the treatment is successful. CRP remains low from the prednisolone. And just one last thing to mention about after the IV infusion, because a lot of people thought that, oh, we've given the IV infusion, our job is finished, patient's fixed, we're happy. But do remember that one dose of IV may not be enough to replenish the patient's iron deficiency if their HB is low enough or their iron store is depleted enough. Some people may need repeat iron infusion in a couple of weeks' time. But what I prefer is to encourage people to go back on maintenance oral iron therapy, because it's cheaper, less risk. And once they have their initial need replenished, i.e. they have a loading of iron, usually their symptoms will be improved enough that they can maintain with ongoing supplements of oral iron. But if we forget that, then they will be half replenished, and then 6 weeks later, you'll find they're in the same situation again. And obviously, the most important thing is to look for the underlying cause of iron deficiency, because unless we fix that, the patient will come back to you again with the same problem. Iron infusion is not the treatment for iron deficiency anemia entirely. And just final gems for you to take away if you work in renal or cardiology department, the definition of iron deficiency in those groups are different because they have quicker iron turnover. So they will start replacing iron at a much lower threshold than what I said before, which is ferritin of less than 30 and transferrin saturation of less than 20. So just something to note. Finally, take-home message. Iron deficiency can still be present despite normal MCV, and taking a clinical history and doing other markers are important. We need to be aware that iron deficiency can cause, iron infusion can cause side effects and the risk of permanent skin pigmentation. Also watch for hypophosphatemia and monitor vitamin D. And if we're going to prescribe iron infusion, be prepared to deal with some reactions because they're pretty common. All right, so I think that's the entirety of my talk. I will look at what's popped up since then, and then people can ask more questions. So one question is, does pigmentation become apparent during the infusion, or does it take time to appear? So it takes time to appear, because I think ultimately is a leak. So you'll probably see a little bit during the infusion, but an infusion of iron can only take 15 minutes. So before you know it, it's already all in the skin. So it will probably appear by the end of the infusion, but the skin will usually be swollen and a bit red, so people are less conscious of it. But it's only after the initial redness and the tenderness disappear, it's like a leaking drip, then the blackness becomes more evident. And also, depending on your background skin color is, if you are fair skin color, it will also stand out a lot more and a lot quicker versus someone who's already had dark pigmentation as their baseline skin tone as well too. So yeah, the whole idea I tell patients these days is, if you feel pain as the infusion goes in, i.e. there's a problem with the drip, call the nurse to stop the drip immediately and examine whether the drip is leaking. How soon after the iron infusion can we expect to see the changes in FB? So generally the changes come as soon as a week, because iron infusion is 100% bioavailability. So, you know, if you do daily FBs, you'll probably observe 24 hours later, your iron levels will start to go up. But your HB would probably only increase in about 2 weeks' time. And the full effect of a HB gain would probably be seen after about 4 to 6 weeks. Same thing for oral as well, but oral is much slower, so it's minimum of 6 weeks. Anyone else have any questions?
It doesn't appear like there's any more questions, so I'll just say thank you very much, Teresa, for a great talk. I think everyone would have taken something new away, which they can hopefully apply to their practice going forward. We'll do the raffle after and message whoever the winner is after, so we don't have to